Regenerative Centers, a private limited in Trichy. And he has been in the field of orthopedics for over 3 decades and also in the field of regenerative medicine for almost 2 decades. And he is also the president of the Indian Stem Cell Research Group, Study Group. And he has also played a very pivotal role in introducing the first approved allogenic stem cell therapy for critical limb ischemia and osteoarthritis. I think these are very, very important areas. And he has a lot of experience in treating diabetic foot ulcers also. And he also supplies lyophilized platelets and also platelet-rich plasma from his bank. And he has also been a very important part, played a very important part in government-funded projects of DBT, etc. And currently, he is into a clinical trial where it uses the stem cells in improving the survival of the corneal cells that are ready for a corneal transplant. I think without wasting much time, I invite Dr. Ravi to give us a talk on the approved stem cell therapies in our country and introduce us to this new area in medicine. Over to you, Dr. Ravi.
Thank you. Thank you, madam. It is really a very great honor to be introduced by my senior, Dr. Sujata Jagdish, madam. So, she has been one of the leading lights of this group. And as all of us know, the last lecture which she delivered was an excellent presentation on the genetic diseases. So, and I thank Dr. Venkatesh who has taken all the efforts to bring this into this format where we can learn as well as spread the knowledge to our the upcoming generation. So since I am traveling, so I thought Dr. Venkatesh will share the screen for me. So today's topic is about the Indian government DCGI approved stem cell therapies. So there are, as I will be showing, there are few stem cell therapies which are already approved in India. So in my first slide, actually, I asked the question in every talk of my this DCGI approved stem cell therapies. My first slide is next Venkatesh. So it is stem cell therapy approved in India. So most of the people don't know that it is already approved. So the first approval came in 2017. I am specifically talking about the mesenchymal stem cells. So in our subsequent slides, I will be saying about what are the stem cells, a few important points about the basics of stem cells, and then about what are the current approved stem cell therapies. And finally, I will be talking about the future also. So what we can expect in the near future.
Project பண்ண ஆரம்பிச்சிருக்கோம் சார் slides.
Yeah, next slide.
Slides project பண்ண ஆரம்பிச்சிருக்கோம் சார். அதனால வரலையே அப்படி.
So yeah.
Project ஆல சார்.
Yeah, next Venkatesh.
Sir, can you see the slides?
இல்ல சார் வரல சார்.
No, it's not moving.
Sir, can you see the slides now?
Yeah, is stem cell therapy approved in India? That slide is there. Next slide, please. Yeah. So I want to project the pioneers in stem cell therapy. You can see that all of them are from India. So I want to showcase the pioneers of stem cell research and therapy in India. So there are green ticks, there are yellow ticks, and there is red tick also. So green ticks are all approved therapies, yellow are ongoing projects, and red is not even started for phase 1 clinical trial. So all of us know that Dr. Surendran, who started the stem cell lab in Stanley Medical College way back in 2008. So he is considered to be the father of stem cell therapy in India, because it was one of the first labs which was dedicated for liver disease. He specifically started this stem cell lab in Stanley Medical College because he thought that a chronic liver disease cannot be cured with the present available treatment of liver transplant, which is not going to be available to every patient. So he wanted to see how he can help many patients if they cannot undergo transplant, what next can they be subjected to. So then Dr. Sujata Mohanty is actually the director of stem cell lab in AIIMS, Delhi. So Delhi also started a stem cell lab way back in 2006-7, and then a lot of work is being done in AIIMS, Delhi on stem cells in multiple specialties. And the green tick for Dr. Sujata Mohanty is for the critical limb ischemia work, which has already, she was one of the principal investigators. The AIIMS Delhi Vascular Surgery Department was involved in the clinical trial, and now the product is available in India. So the green tick. The yellow tick is for again in AIIMS Delhi, that is for the fistula in ANO due to Crohn's disease, recurrent fistula in ANO due to Crohn's disease. It is phase 2. Phase 2 clinical trial is ongoing in Delhi. So that's why I put the yellow tick. All of us, most of us know Dr. Rosie Venila and Dr. Sekunda Anand. So these two are the prime scientists who are scientists, clinician scientists who are who have taken up the work started by Dr. Surendran, and they are looking after the Stanley Stem Cell Lab. Dr. Rosie Venila has retired, and now Dr. Sekunda is in charge of the stem cell lab. And yellow tick is because they have already obtained the government approval for starting phase 1 clinical trial for chronic liver disease with mesenchymal stem cell therapy. So then Dr. Rajkumar, many of us know, he is a vascular surgeon. He was a HOD in both Stanley and then later also in Madras Medical College, and he was the principal investigator. And his study helped the approval in the approval process for critical limb ischemia. And today stem cells are available for critical limb ischemia due to the work of Dr. Rajkumar and in Delhi AIIMS. Then Dr. Cherian is a very popular cardiothoracic surgeon. He did a lot of work on cardiac stem cells, particularly for cardiomyopathy, but it has not come up. He has completed animal trial and he has done few clinical cases also, case series, but a clinical trial has not been started. So that's why I put the red tick for cardiology. And then, yeah, Dr. Namita Bhuvaneshwari is actually Mrs. Dr. Rajkumar, and Dr. Namita had been the director of the regional eye hospital. So all of us know that in ophthalmology, limbal stem cell therapy is being done for the past 25 years, 25 to 30 years. So they were the first people to find out that stem cells are there in every organ. It is there in the cornea. How can we take the stem cells from cornea and use it for a pathology in the cornea? So Dr. Namita has been in the forefront of the research on limbal stem cell therapy, and that is already, it was approved since 2014. It was available even commercially. So that's why the green tick. Then Dr. Vineet Ahuja is the gastroenterologist who is currently doing the phase 2 trial for Crohn's disease, recurrent fistula in in AIIMS Delhi, and that's why the yellow tick. And Dr. Colonel Pawan Kumar Gupta is actually the main person for both the products which are today available in India. He is a scientist in STEM1, which is a Manipal University's company. So he has been in the forefront of translating this stem cell research into treatment. And the green tick is for both the therapies for osteoarthritis and critical limb ischemia, thromboangiitis obliterans, and all the other 6 indications. And yellow tick is for the 2 works. One is the Dr. Ahuja's work on Crohn's disease, and 2 more trials are ongoing for actually diabetic foot ulcer. The trial is over. Only the presentation phase 3 trial is over, but the DCGI has to give the final approval. So next slide. So this is actually not a talk, as this is actually storytelling. So this is a story about stem cells. It is my story, it is your story, and it is our story. And as all stories start with once upon a time. So today I am Ravi, but once upon a time I was a stem cell. So next slide. So all of us start out as a stem cell. We become a ball of stem cells and the embryonic stem cells. Then we become a bag of stem cells. Then we become a body of stem cells. And finally, you see, we can live forever and contribute to the world by donating our stem cells. So the last part is actually, yeah, when we, any person from the cadaver, the last organ that can be retrieved is the stem cell. So by donating your stem cell, you can live forever. So I am actually a Kamal fan, actor Kamal. So my aim is not to give a book on stem cell, but open the doors to stem cell. Let's go, let's explore. And each of us should definitely do this. And always like Rajini Kamal. So I want to clarify here itself that what I am talking about. When I'm talking about stem cells, all of us know that there are two major types of stem cells, hematopoietic stem cells and mesenchymal stem cells. And hematopoietic stem cells are like Rajini. So they do only two things, like his fighting and yeah, his style. So they are useful in cancer. Hematopoietic stem cells, all of us know it is useful in leukemia, lymphoma, and also it is useful for blood dyscrasias like sickle cell anemia and thalassemia. So these are only the two types of diseases for which hematopoietic stem cells are mostly used. But like Kamal, this mesenchymal stem cell is definitely it's the multivarious functions it can do. And for older generations like MGR and Shivaji, MGR was like only style and love, whereas Shivaji could play so many roles. So like that, the mesenchymal stem cells can play so many roles and they can be useful to many diseases. Subsequently, we will be seeing that many more diseases we are going to treat in the future with mesenchymal stem cells. And like Rajini, this hematopoietic stem cell has been called as bone marrow transplant. So nobody knows Rajini as Shivaji Rao. So nobody talks like hematopoietic stem cell therapy. Everybody says it is bone marrow transplant. But by saying bone marrow transplant, they mean it is hematopoietic stem cell. So when they say bone marrow transplant, they mean hematopoietic stem cell. And this mesenchymal stem cell is what I am going to talk. And it is an evolving and trending story. So Thug Life. So MSc for GVHD is the latest Thug Life release. So MSc for GVHD was approved in USA in December 2024. So that's the latest release, like Thug Life. Next slide. Next, Dr. Venkatesh. Dr. Venkatesh, next, please.
Sir, just a minute, sir.
Yeah. So as I said, this talk is mainly about mesenchymal stem cells in detail, and I am not going to talk about hematopoietic stem cells or the bone marrow transplant. That's a different topic. Next slide. So a small introduction about stem cells to this August audience. I think most of us know that stem cell has got the property of self-renewal as well as the property of differentiation. So it can self-renew itself for a very long period of time, and it is a small pool of stem cells which is always available in in all of our organs. And then whenever there is an injury or a loss of the cell, these stem cells can differentiate and replace the damaged or the degenerated cell. So the stem cell has got this property of self-renewal as well as differentiation, and that is guided in the niche by the demands of the body. So next slide. So these types of stem cells, most of us know that the embryonic stem cells, which we the age from the age cell stage, so they are totipotent, then they become pluripotent, and by the time we take it from the umbilical cord, they are multipotent, and then in the tissue they are oligopotent, and finally unipotent, so that they can differentiate into a typical uh, uh, cell of that organ, whether it is a hepatocyte or whether it is a neuron or whether it is a glial cell. So depending upon their differentiation capacity, they can be anywhere between a totipotent and a unipotent cell. Next slide. And then depending upon the origin from where we take the stem cells. So from apart from what we get from the umbilical cord, even in the adults, we can retrieve stem cell from every tissue. So every organ, every tissue has got some amount of stem cells. Now we know where is the niche, where to take the stem cells, and if we take the stem cells, which are the diseases we can use. So we can take it from the bone marrow, we can take it from the fat. They're already from the limbus, the ophthalmologists have taken limbal stem cells and used it for corneal blindness. So from every organ, as I said, from the hair follicle, we have taken stem cells. So we have taken stem cells from the dental pulp. So from the tooth, we can take the stem cells and then culture them, increase the number. So depending upon the organ, the adult stem cells can be retrieved from so many different organs. Next slide. And these niches have been not only been identified and named. So for example, in the eye cornea, we know the limbal stem cells are found in the crypts of oak, the palisades of oak. Similarly, in the intestine, they are again found in the crypts of Libercoon. So, and in the kidney, they are found in the renal papilla stem cells, and lung. In the bronchiole, they are the Clara cells. In the alveoli, they are the type 2 pneumocytes. In the hair, in the bulge of the hair follicle, you can find the stem cells. So now we know where to search for the stem cells and stain them. We can identify by staining them, and we can also prove that they are the stem cells by differentiating them into the adipose or the osteogenic differentiation capacity. So now we have the technology to identify the source, take the stem cells. If needed, we can concentrate them, or if needed, we can culture them, and then how to use them for different indications. So stem cells are not only used as therapy, they are also used for the research also, and for drug discovery. So for personalized drug therapy, stem cells, induced pluripotent stem cells are used for drug discovery. So this stem cell research is not only helping us in treating, but also in drug discovery and other modeling of the diseases also. Next slide. So what is in the bone marrow? See, all of us know that bone marrow is a very good source of stem cells. And you know that there is a niche. I was talking about the niche where these stem cells are found. So there is a periosteal niche and there is a perivascular niche. So as you see, the niche around the vascular channels are less hypoxic, whereas the niche in the periosteal area is more hypoxic. So the more the hypoxic, you can find the stem cells are more potent. So as they move, as the hematopoietic stem cells move towards the perivascular niche, they start differentiating, and then they become bipotent or unipotent, and finally they become either a RBC or a WBC. And then when they enter the blood vessel, they are already a differentiated cell. So in the bone marrow, in the deep hypoxic niche reside the most potent stem cells, whether it is the hematopoietic or the mesenchymal stem cells or the endothelial progenitor cells. And the periosteal, the osteoblast are also part of the niche. So it is the the crosstalk between these stem cells, the mesenchymal stem cell, the hematopoietic stem cell, the osteoblast, the endothelial, they talk to each other and they decide when to differentiate, what to differentiate, and how they can help. So that is the importance of knowing about the niche. Next slide. Similarly, as I said, the niche is there in every tissue, and we have to identify the niche and then take the stem cells. So cord blood, all of us know, is a very good source of stem cells. You can see that the cord blood, which is present in the umbilical vein and the umbilical arteries, that has got the hematopoietic stem cells predominantly. There are very little mesenchymal stem cells in that. Whereas in the cord tissue, the Wharton's jelly, which is in the cord tissue, contains predominantly the mesenchymal stem cells. So depending upon what we want, we can either use the cord blood if we want hematopoietic stem cells, or if we want mesenchymal stem cells, we can go for the cord tissue, which is a very good source for mesenchymal stem cells. Next slide. So two myths for more than 100 years. I just want to bring it to your attention. So brain cannot regenerate. It has only plasticity. It has no regenerating ability. So 100 years ago, the father of modern neuroscience, Ramon Cajal, a Spanish physician, recognized that injured brain could not repair or regrow the damaged neurons. Cajal stated in adult centers, the nerve paths are something fixed, ended, immutable. Everything may die, nothing may be regenerated. It is key for the science of the future to change, if possible, this decree. So, has that changed? Is the brain capable of regeneration? Are there stem cells in the brain? So, we have to see whether this myth has been broken. He said it probably in 100 years ago. It was 1925 when Raman Kajal said this. Similarly, Frederick Banting, 1925, when he invented this insulin, in his Nobel Prize lecture, he emphasized that insulin is not a treatment for diabetes. It is a treatment for diabetes. It is not a cure. And he said we should aim for a cure. So beta cells should be made to produce insulin again. You cannot keep on substituting the insulin. At one point of time, we should find a way to regenerate the beta cells. So this is not my words. This is the words of the the Nobel laureate. So human brain, does it have stem cells? So there are articles which I have just shown, where they have shown while doing surgery, when they did lobectomy, temporal lobectomy, for probably the seizure patients, they analyzed the brain, and then they found out that stem cells are present in the human brain. So wherever you search, you find that animal brain, mammalian brain has got stem cells, fetal brain has got neural stem cells, but even the adult human brain contains stem cells, and that has already been proved. And so that myth is also broken, and brain can regenerate, but the capacity is so little. So there is a wide variation between the different tissues. The gut can regenerate fast, the liver can regenerate fast, the skin can regenerate fast, but the heart or the brain or the cartilage cannot regenerate so fast. That all depends upon the pool of stem cells. How much of the stem cells, how much percentage the stem cells make in the making of the organ, so making of the tissue. So that will determine how fast or how capable the organ is in regenerating. Next slide. So coming to the main topic, it is the Indian government approved allogenic stem cells. Then gene therapies, I will also talk about something about the CAR T cell therapies, because it's all about cell therapy. So these three pictures which I have shown, the first bottle is the stem 1. So that is for osteoarthritis. So it is available for any orthopedic surgeon in India who has got a stage 2, stage 3 osteoarthritis patient. If they want stem cell therapy, if they don't have a deformity, gross varus deformity or valgus deformity, then this is available as a treatment option. This was approved in 2022, but much before that, the other two stem cells, that is for critical limb ischemia due to Burgess disease, as well as critical limb ischemia due to peripheral arterial disease in the diabetics. So for Burgess disease, actually the approval was in 2017, but the product was available only since 2021. Similarly, for diabetes peripheral arterial disease, the approval was in 2020, but the product is available only since 2021. And then there are three other indications for skin regeneration, for hair regeneration, and under eye dark circle, where when the stem cells are cultured and then the oxygen supply to the stem cells are stopped for 6 hours. Overnight, oxygen supply is stopped to the stem cells, and then they secrete all the growth factors into the medium in which they are cultured. Then you can remove all the stem cells and use only the medium, which contains the essence from the stem cells, that is called conditioned medium. And so this conditioned medium is approved for skin regeneration, for hair regeneration, and under eye dark circle, and it is available in India. Again, it is available through the company Cipla. So, and then limbal stem cells, as I said, since 2014, Reliance had a science company by name Relicell. It was a bioscientific company from Reliance. So they were culturing stem cells and then supplying it to the ophthalmologists for corneal blindness. So, as I said, India is the only country in the world with 7 approved stem cell therapies, all of them mesenchymal stem cells. So, and all of them are allogenic. So, Korea has some, Japan has a few, but India has the maximum. Gene therapy available in India, Zolgensma is approved in 2020 by US FDA, and it is available to Indian children. It is only imported. This is for spinal muscular atrophy. So it is a gene therapy. There are 3 types of gene therapies available for spinal muscular atrophy. One is a small molecule therapy, and whereas this Zolgensma is actually the gene therapy, which has to be imported. It is very, very costly. The cost is around 21 crores. So for one patient, for every patient, they do a crowdfunding. So they do the crowdfunding and then they give the treatment for these children. So it's not easily available. It's very, very costly. And immune cell therapy, CAR T cell therapy, where they engineer, it is genetic engineering of the T cell. So all of us know that T cells are capable of taking on the antigens and the cancer antigens. You can genetically engineer them so that the cancer cells are killed, and the most identifiable target is the T cell, CAR T cell, where it is chimeric antigen receptor engineered T cell. So similarly, a natural killer cell is also being tried, but what is already approved? I am only talking about approved cell therapy. And so in India, CAR T cell therapy is approved, and the company is called ImmunoAct, and they are IIT Mumbai associated company, and it is available since 2023 for B cell leukemia. It is specifically for B cell leukemias. So next slide. Yeah, next slide, Doctor. Yeah. So these are again the conditioned medium product, as I said, for the hair regeneration, for the skin regeneration, and under eye dark circle. Next slide. So these are all available in India. So next slide. So this is the approval letter. So many people don't believe when I say that stem cell therapies are approved. So that is I post this approval letter. So you can see that in the
But the patient is not symptomatic, is comfortable, good urine output is there, potassium is normal,
Bicarb is normal. As therapy they are present. So
I think somebody is to be muted. Yeah. Yeah. Okay. So this is the approval letter from the DCGI, which I show in most of the talks because people want to know the exact date of approval. Next slide. Other countries also have approved stem cell therapies. As I said, Japan for Crohn's disease, what we are already doing phase 2, they have completed phase 3. For recurrent fistula in ANO, fat-derived stem cells are approved. And then again, for GVHD, it is already approved in Japan. And autologous, the only country in the world where for neurological indications stem cell therapy is approved is Japan and Korea. So for Parkinson's disease, they have approved autologous fat-derived mesenchymal stem cells, cultured mesenchymal stem cells, 5 doses. Each dose is 200 million stem cells, out of which 150 million is given intravenous and 50 million is given intrathecal. So that is the only neural condition so far which has got approval throughout the world. And it is approved since November 2023 in Japan and in South Korea. As you can see, for osteoarthritis, already they have a product since 2012 by name Carticel. There are other UCMSC, that is umbilical cord, is approved for other indications also. And for North Korea is also the cells for the Parkinson's disease are actually manufactured in, not in North Korea, in South Korea and Japan. Then Europe, again, Crohn's disease, then for cornea, limbal stem cells, and for cerebral palsy through a specific approval process, they have, that is called as an expanded access program. So they have made umbilical cord stem cells available to children with cerebral palsy. Similarly, for cerebral palsy, children in Australia and children in USA, they have got a special approval process, which is a special access scheme. In Australia, last month, 2-3 months ago, they gave the first child with this through this process. And again, in USA, it is available since 2017. But for GVHD, the first mesenchymal stem cell cultured bone marrow derived for GVHD in USA got the approval in 2024 December. So if a patient has got a diabetic ulcer, non-healing ulcer, and if it is due to multiple blocks in the blood vessel and where the vascular procedure cannot be done either because of the multiple blocks or very distal blocks, or even after the failure of the endovascular procedure, if these patients are called as no option critical limb ischemia, and they are a small part of these diabetic ulcers. They are and for them this stem cell therapy is the only option. Any patient in USA or in Europe or in Singapore, which are all more developed countries than us, that patient has to come to India. Any patient has got osteoarthritis in USA, in Europe or in Singapore, if they want a stem cell therapy, they have to come to India if it has to be approved. For unapproved, they can go to Mexico, they can go to Thailand, they can go to other countries. But if they want approved, government approved stem cell therapies, they have to come to India. And that is the reason I say that medical tourism is bound to bound to increase in India in many fields, specifically in the field of stem cell therapy and regenerative medicine. Next slide. So this is just a small thing about the cerebral palsy. As I said, while there are no drugs to treat, the stem cells can both treat and prevent cerebral palsy if you give it in the early stage itself. Usually we diagnose cerebral palsy after some time. It's not diagnosed at birth. So whereas at birth, when there is a hypoxic ischemic encephalopathy, and if at that stage stem cell therapy is available, the same child's stem cells, cord blood stem cells stored, and if is given, then it can prevent the onset of the cerebral palsy. So that is the finding from this study. Next slide. So graft versus host, the more point about this. So there are 2 types, and the mortality is very high. And this approval is for the steroid resistant variety. So this is for the steroid. All of us know that graft versus host disease is very difficult to treat. Steroid is the only option apart from the other immunosuppressive drugs. And when even the steroid fails, there is nothing else we have to offer. And it is in such no option cases that these stem cells have been approved. So I want to emphasize again and again that stem cell therapy is not for all diseases, it is not for all organs, it is only tried for cases where there is no treatment, no cure is available. So nobody is going to do stem cell therapy for cataract. So because all of you know, today morning you have a cataract and then you go get operated, and by afternoon, evening, you are back home with a 100% vision. So where there are no drugs, then these stem cells are being tried for one disease after the other, and you can see slowly the number of diseases which are getting approval for stem cell therapy are gradually increasing. Next slide. So the mechanism of GVHD and then the treatment, this slide I deliberately left to Dr. Murali to explain, because I think he will be in a better position. So at the end of the talk, if we want to know a little more detail about GVHD, how it happens and how, if it has to be treated, what are the steps which have to be rectified. So next slide. So the next slide talks about how mesenchymal stem cells have the effect on the T cell, the B cell, the dendritic cell, the macrophage, how it converts M1 macrophage into M2 macrophage, and what is the effect on the natural killer cell, and how all this combined effect can help in the correcting the GVHD, affecting the multiple organs. So GVHD affects the intestine, it affects the skin, it affects the eyes. So it is not possible for a single cytokine to be targeted. There are monoclonal antibodies. All of us know that they are now one of the biologicals. One route for biological therapy is the monoclonal antibodies. But you have to know that in the body there is always multiple a chain reaction of the cytokines and how they affect the system. And if you want to correct the pathology, how you have to address every part of that. It's not possible to address that with a single cytokine. So that we will be learning soon. So that is the difference between, when you say biologicals, there are monoclonal antibodies that are also biologicals. This is cellular biologicals. These cellular biologicals, particularly stem cell biologicals, are multi-pronged. They have a multi-pronged action. And so that is how you can really address a disease. Next slide. So these two slides, doubts will be cleared by Dr. Murali, the mechanism of action. So the approved stem cell therapy, a little more detail. This is you can see the bag, which contains 150 million stem cells, and one more pack is available with 200 million stem cells. And this is for both the thromboangiitis obliterans as well as diabetic foot ulcers. And these are bone marrow derived, cultured. This is from Manipal University. As I said, they have a company called Stemputics. They did all the research. 25 years they have did this research, and they have taken it to the drug controller. Every animal studies, then phase 1, phase 2, phase 3, everything was submitted to them, and finally they got the approval. And the dose is 2 million per kg body weight. Suppose a patient with a non-healing diabetic ulcer with multiple blocks, no option critical limb ischemia, if he is 70 kg, we will buy this 150 million bag, stem cells containing pouch. And these cells are sent in a liquid nitrogen tank. So it takes 3 days. You give an order from my pharmacy, the order will go to the Manipal University, and from there, from Manipal, the cells will be shipped. It will take 2-3 days. It will come in a liquid nitrogen tank, because you need cold chain. You need a cold chain to maintain the cells. And then once you receive it in the OT, you can open it, thaw it, and then inject it into the limb. So For critical limb ischemia, it is injected intramuscular. So it is not injected into the artery, though it is the artery that is blocked. The stem cells are given only intramuscular and perivascular, close to the blood vessels, but not into the blood vessels, because they act by forming collaterals. They don't open up the blocked blood vessel, but they open collaterals which sustain the limb. So next slide. So this is the study, the clinical trial study, which was submitted to the DCGI for approval, showing the phase 1 and phase 2, and ultimately the phase 3 also, about the safety and efficacy of allogenic bone marrow derived mesenchymal stem cells for critical limb ischemia. Next slide. So these studies were, again, as I told, our Dr. Rajkumar sir, and in Delhi, the AIMS Delhi, the vascular surgery department were part of this study, where they proved that there is improvement in the ankle pressure, and the ankle brachial index improved, and the pressure increased more than 70 millimeters per mercury, and the digital pressure, the pressure at the digital level increased more than 40 millimeters of mercury. So next slide. And this is what they had shown by MR angiogram, the angiogenesis, which has happened after the injection of the stem cells, how the posterior collaterals have opened up 6 months. Though this is demonstrated 6 months later, but already the limb does not progress for amputation. So they have saved a lot of limbs from amputation. Next slide. So I will just show few of my cases. So this is a case of thromboangiitis obliterans. This is a 42 years old male, chronic smoker with claudication pain, non-healing ulcer in the toe and the distal pulses. He is a vascular surgeon. It was referred by cardiovascular surgeon. It is our own senior, Dr. Sendil, cardiothoracic surgeon. He referred this patient to me. With no option. And then for amputation, I did not do the amputation. Next slide. So after injection of his own stem cells, at that time, this product was not available. So I took the stem cells from the patient's own iliac crest. So we put a needle into the iliac crest and aspirate the bone marrow from the iliac crest. And within 30 minutes, we can do the FICOL method. FICOL method is what we learned in our physiology when we were in MBBS, in our physiology lab. We would have done the FICOL separation method, density gradient. So that way we can separate the mononuclear fraction, which contains the stem cells, and you can see the pre and post, before and after. It is not the block vessel doesn't open up, but it is the small collaterals which sustain the distal part of the limb, the ulcer healed, and even now it is 8 years since injection, and the limb has not yet been amputated. He is a smoker. 4 years after this first injection, which we gave in 2017 or 2018, he came again with rest pain because he continued to smoke. And then we gave a second dose, and now it has not been amputated. So next slide. This is actually, the first one was a typical TAO, thromboangiitis obliterans, whereas this patient is a 65 years old male who is both a smoker as well as a type 2 diabetes. And his CT angiogram showed ephemeropopliteal multiple blocks, and ephemeropopliteal bypass surgery was done 4 years ago, and that bypass got thrombosed after 4 years. And he came back with the same symptoms of claudication and non-healing ulcer. They attempted profundoplasty, that also failed, and then he was again referred by vascular surgeon to me for below-knee amputation, but we did not do the amputation. We did the autologous BMAC. We did the bone marrow aspirate concentrate. And then next slide, you can see that there is a increase in the collaterals around the knee joint, and the new collaterals have developed, and that is how that limb survived. And again, he did not undergo further amputation. So next slide. So you can see this angiogenesis. We will talk about this angiogenesis and neurogenesis. So please remember this sentence. Angiogenesis is coupled with neurogenesis. Please remember this. We will talk about this later. So diabetic foot ulcers, we have treated some of these cases are actually Dr. Ramachandran's case. We were all together, myself, Dr. Ramachandran, our teacher, plastic surgeon from Trichy, excellent work. He has got his own lab in Trichy. We were together in Maruti then when they separated from Maruti Hospital. They started, he started a stem cell lab, and these diabetic ulcer cases or his cases. Next slide. Which we had done at Maruti Hospital. So you can see complete healing of the ulcer without skin grafting. It is not only the healing of the, usually you get a healing in the foot, but the quality of the skin will be so poor that the ulcer recurrence happens. But when the healing happens with stem cell therapy, the quality of the skin is much, much better, and the recurrence of the ulcer is much, much low. Next slide. Actually, this is a 3D printer from South Korea, which was approved by the Alchem company tried to get this approved in India. So this is a 3D printer which I had used for a case of diabetic ulcer. So here you can see this 3D printer it's a tabletop. So it can be sterilized and it can be taken inside the operation theater. So once it is taken inside the operation theater, you can see there are two cartridges. That blue ring and the red ring, they are the two cartridges. And one cartridge, we have to put the patient's own fat stem cells. The plastic surgeon takes the liposuction, and then we prepare the stem cells from the lipo, aspirate, and then put it into one cartridge. And the other cartridge has got the fibrin glue, fibrin and thrombin combination. And this 3D printer, you can take a photo of the ulcer. So 3D camera. So it is provided with a 3D camera. So you can take the photo of the ulcer inside the OT, the same length, breadth, the border, the thickness, the depth, everything in 3D, it is recreated. That photo is sent to this 3D printer via Bluetooth, and then from the cartridge, you can see that the same size, shape, the printing, 3D printing is going on. Next slide. So this is the ulcer on which we kept the 3D printed patch. The 3D printed patch looks like omelette. So it is the consistency of an omelette because it contains the fat and the stem cells within the fat. And that is what helps in the healing of the ulcer. So next slide. So here you can see the 3D printed patch, which is placed on the ulcer. And this happens within 30 to 45 minutes. So liposuction takes 10 minutes. The 3D printer takes 30 minutes, 20 minutes, 30 minutes. And by 30 to 40 minutes, you have a 3D printed patch, which you can keep over the ulcer and then do a bandage. And this patch helps in the quick healing of the ulcer. Next slide. So that is about the ulcers, and now I come to the osteoarthritis part. So STEM 1, this is the product which is available in India since 2022 for osteoarthritis stage 2 and stage 3. So at least for 1 year there is pain and stiffness relief. That is what they had proved. But in our studies, we have more than 4 to 5 years of the pain relief, and there are minimal side effects compared to what is normally seen. Though the gold standard for severe osteoarthritis, if there is a deformity, suppose a patient has got a severe varus deformity or valgus deformity, we cannot correct the deformity with the stem cell injection. So those patients have to undergo joint replacement. So joint replacement is not replaced. So there is a role for joint replacement, but that is only in cases where the deformity is severe, where the varus is more than 8 degrees, or the valgus, when there is a severe valgus or varus deformity, then only the option of joint replacement. But if the deformity is not severe in stage 2 and stage 3, It is not only the cartilage, but also the meniscus. You should know that the cruciate ligaments are also worn out. They are torn. There is a partial tear of the cruciates. There's a partial tear of the menisci. There's a partial tear of the collateral ligaments. The capsules are lax. They are also torn. So in osteoarthritis, the multiple tissues are affected inside the joint. So stem cells can regenerate every tissue. It is not only the cartilage, but stem cells can also regenerate the collateral ligaments. It can regenerate the cruciate ligaments when they are partly torn, not when they are totally torn and displaced. Then in young adults, they need to be surgery has to be done, particularly like a sports person. When there is a total tear of the say the anterior cruciate ligament, surgery has to be done. But that's not the case in an old patient, say 60 years, 60, 70 years, when there is a tear in the cruciate ligament, the surgery is not going to help because the ligament is already degenerated and sutures will not stay. And in those cases, stem cell therapy is the best option. Next slide. So this is how it is taken. So the stem cells are taken allogenic, as I said, it is taken from another person. So from 3 people, it is taken and they are pooled, taken from 3 young adults, and then it is pooled, and from that you can make from 3 people, what you take, you can make into 3,000 doses or 30,000 doses, and then they have been tried for osteoarthritis, critical limb ischemia, and other indications, as I said, for diabetic foot ulcer and perianal fistula in Crohn's disease, the trial is ongoing. Again, for the disc degeneration also, the trial is ongoing. So in another 1 or 2 years, you will find 3 more indications added to the 7 indications which I have already mentioned. Next slide. So these are a few cases of our cases where we did the stem cell therapy autologous. Even before this product was available, I was using patients' own stem cells taken from the bone marrow. So this is a 55 years old female. You can see the narrowing in the lateral compartment before and after the injection. This is 7 months later. You can see the increase in the cartilage height and volume. And this case was done more than 10 years ago. Next slide. So here also you can see that the medial and the lateral, the medial compartment in the right and left leg. So before and after in a 56 years old female. So next slide. So this is how long the effect lasts. So this is a common question. So in the age group of about 60 to 65 years, if the BMI is within the limits, normal limits, if the patient is not very, very obese, then the stem cell therapy can have an effect for 4 to 5 years with a single dose. So this cannot happen. This can happen up to 60 years, 65 years. You cannot expect this to happen at 75 years or 85 years. So in a selected age group with a selective BMI, and if the patient is willing to do the exercises and keep the muscle strength and keep their body weight low, then the effect lasts longer. So it is we have to choose the patient, and the patient has to understand that if they want the effect to last, then they have to do certain things like weight loss and as well as continuous exercise. Next slide. So it's not with the surgeon alone, it is the contribution has to come from the patient also. So here again, nowadays there are a lot of these MRI, these investigations. We will talk about the current investigations available in multiple fields, which has shortened our time for testing, time for proving. So here actually you can see that this is called a histogram in an MRI. So here it is an autologous stem cell therapy for a partial tear of the ACL. So this histogram, when there is a shift to the left, it shows that the quality of the healing, the quality of the collagen is improved. How do you know that the collagen is reformed? But whether it has improved from what it was before or whether it has worsened. So that now can be to some extent proved by the MRI. So this is a histogram of the MRI picture showing the improvement in the quality of the cartilage. So next slide. Previously, you need a biopsy. So nowadays in ophthalmology, you have got the spectral microscope, which can see the live cells without staining, without biopsy. They can count the number of endothelial cells. The humans have got a constant number of finite number of 3,000 to 4,000 corneal endothelial cells. But somebody who has a disease, has a dystrophy, the number of cells are less. And this microscope can, without a biopsy, it can, without a staining, it can count the number of cells, and using AI, there is no, the microscope gives the report, AI generated report of how many cells are available, in 2,500 are available, and then 100, more than 100 are out of shape. So polygonal normal shape cells, so how many of them are out of shape, which means they are diseased and they're going for apoptosis. So these recent investigations like MRI, these spectral microscope, this NMR. So there are these PET scans. So they show which part of the brain is working. Tractograms, which can show whether the spinal tract has regenerated, whether the injured portion, whether it has healed. So these recent investigations have helped us to know the healing happening without going in for the biopsies. We needed animal trials before. Only to make a biopsy, we have to kill the animal and see whether the beta cell has regenerated, whether the healing has happened. But now we have investigations which can show us, which can reduce the time for all those things. So this is again MRI scan for osteoarthritis treated with stem cell therapy. At 2 years follow-up, you can see increase in the thickness of the cartilage. So next slide. So some of the some of the cases we have our own cases, and some of them these are taken from the literature. So here also you can see a near total tear, which is being healed treatment, and you can see the healing in the MRI. So this is after bone marrow concentrate injection. So next slide. So again, this is platelet-rich plasma for partial knee injury. So where do we use platelet-rich plasma? Where do we use stem cells? In young patients, if the injury is recent, the platelet-rich plasma itself is enough because it contains only the growth factors from the platelets. It is a one-time release. There is no continuous release, but it is a one-time release. So in younger patients with recent injury, platelet-rich plasma is easy to do. Whereas if it is a chronic injury in an older patient, 60 years or 65 years, 70 years, where PRP will not work, then we have to go for the bone marrow, aspirate, and then use the stem cells. So here it was a young patient where it was used stem cells. And here again, you can see the ACL tear, which is healing 50%. And then 1 year after the ACL tear, you can see the complete regeneration of the ACL. Next slide. So again, some of these slides just to show that the recent investigations. Now, actually, I am starting this phase 4 clinical trial for the post-market approval, where we are going to take 3 Tesla MRI of the knee joint to show the cartilage recovery. So only 1.5 is available in most of the towns and cities in India. Only 1.5 Tesla is available. There are very few 3 Tesla machines are available. So one is available in Madurai. KG Scans is available in Madurai. So we are going to take our patients to Madurai because we want to do a 3 Tesla scan to prove the changes, the soft tissue changes, cartilage, the meniscus, the cruciate, all these changes in a 3 Tesla are brought out much better. Next slide. So again, for the meniscus tear. So people think also meniscus cannot heal. No, even the meniscus can heal. So as I said, when cornea, which is avascular, when ophthalmologists can regenerate cornea, which is avascular, why not cartilage? Why not meniscus? So we were cutting and removing the meniscus, thinking that the meniscus once damaged, it cannot repair. So unless It is a bucket handle tear which comes in between the condyles and locking the joint. Then we have to excise. Otherwise, we can heal the meniscus also. Next slide. So this is again one more case. This is MRI for 23 out of 20. This is a study which I am quoting from the literature showing the regeneration of the soft tissues inside the joint. Next slide. So this is again one more slide regarding the same. So next slide, showing the thickness. So now we come to the future. So I have finished the current approved therapies. So now we are going to the future where what we are doing today will get approval in the future. So this is in our lab. We have made bone tissue engineering, which means where we can grow the stem cells into an osteoblast, and then once we inject them into the bone, this can produce the defective bone can be formed. So this is bone tissue engineering. You can see the alkaline phosphatase staining happening after we cultured the stem cells on the beta tricalcium phosphate or on the collagen, beta tricalcium phosphate, hydroxyapatite. These are all scaffolds. And when you grow the stem cells on the scaffold, you can get the particular differentiated cell. Suppose you have a scaffold of liver and you put stem cells into the scaffold of the liver, you will get only hepatocyte. If you have a scaffold of bone, a honeycomb appearance, if you recreate the nanostructure of the bone and you put a stem cell into that, it will only become a osteoblast. So it is not only the chemical cue, it is not only the chemical signal, it is not only the hypoxia, it's not only the other niche factors, it is also the physical clue. So you should understand that mesenchymal stem cells, they differentiate, they de-differentiate. Then there is the recently we heard in a conference in diabetology where I attended last week, they were talking about beta cells de-differentiating, and then alpha cells are becoming into beta cells. So the stem cells can go forward towards differentiation into a specific cell type. Then when there is an injury, they can de-differentiate. Then they can trans-differentiate also. One type of cell can become another type of cell. So all this is happening inside the body while we are sleeping. So it is all happening by nature. It is the injury, it is the cytokines, it is the niche which is the homeostasis, which directs the repair process in which these stem cells can go forward and backward and complete the repair in the smoothest possible way. Next slide. Our job is just to help it. So again, in our lab, so we have one more project which was approved by the Chief Minister's funding with Madurai Kamaraj Universities and Dr. Grace Kennett Hospital from Madurai. Our Captain Dodd is there. So he is doing a phenomenal work and taking up burns cases. You know, Grace Kennett is known for taking up burns cases for almost a century. So they have a huge responsibility. They treat burns, particularly pediatric burns. So we are trying. They have a cadaver skin bank. So not recently, few years back, Dr. Augustus was worked hard to get the skin bank approved. So Grace Kennett has got a cadaver skin bank where they take and store cadaver skin. And now our project is to get the cadaver skin from the skin bank, decellularize it, remove all the cells from that, and then from the patient's stem cells, we take stem cells from the patient and put it into this cadaver skin, which is decellularized. As I said, if you put the stem cells into a particular scaffold, if it is a skin, then it will only become a skin. So this project, which was approved by the Kamaraj University, involves a 3D printing of these cells over the decellularized cadaver skin. So that is one more project which we are going to do. And very recently, Today, I was very, very happy to be associated with Rajan Eye Care. My senior, Dr. Sujata Mohan Rajan is there in Rajan Eye Care. And so we had a wonderful conference today. And one of our projects is this cadaver cornea, whether we can extend. Already they have a storage solution which kept it safe for 1 day. Then they had another solution which could save it for 3 days. Now they have another solution called Cornisol, Optisol, which can extend it for 7 days. Now we are trying to see whether we can extend it more by using some of our products, like our plasma products or our stem cell condition medium products. So what is the concentration, ideal concentration of these growth factors and cytokines, which can help in keeping the cornea healthy? It is actually, there are articles saying that the cornea is healing outside the body. So I am repeating again, the cornea is healing outside the body, provided you give the proper the storage medium and the condition medium. So if you store it in a medium which contains the components for the tissue culture, then healing can happen outside the body. And that is what we are trying to prove. And then the same thing will be applicable for all organs, even a kidney which is taken in Chennai and it is transplanted for somebody in Trichy, 6 hours. They are trying to keep it alive, perfuse it. They have cold perfusion, they have warm perfusion, and then they try to keep it alive, minimize the injury. And now, whether we can impregnate some of our growth factors, even there are articles which have shown that by infusing stem cells into the perfusate, they have healed, they have reduced the inflammation of the kidney, of the donor kidney, has become better by the time it is transplanted to the recipient. So these are in the future. Already these research are going on. As I've already posted in our group, there is one team in Australia. There is an Indian scientist who is working in Australia. He has done this for lung. His name is Dr. Keshavji. So they have done this stem cell perfusion for a lung which is to be transplanted, and they have shown that it has improved the quality of the transplant. It prevents not only acute rejection. In cornea, they have shown that it is also preventing the chronic rejection, which can happen 5 years later, 10 years later. So these are all the future of stem cell therapy. Next slide. So we are almost coming to the end of the talk. So which are the specialists who are already using PRP stem cells? Dermatologists are using it for hair and skin regeneration. Orthopedics, we have already converted from steroids. We were injecting steroids everywhere. We were injecting into the muscle, skin, bone, fascia, ligament, everywhere we were injecting steroids. But we found out that steroid can temporarily only relieve the inflammation, but they worsen the pathology. Now we are injecting platelet-rich plasma and stem cells, which reduce the inflammation more than the steroids, but they also help in regeneration. So out goes the steroids. So steroids for chronic use, it has to be curtailed. We are already using it out of syllabus. We are already using it off-label. So they were not approved for many indications which we are already injecting. Steroids are misused. Antibiotics are like how antibiotics are misused. Steroids are also misused. There are only specific acute indications and neurological conditions, but most of the other indications we are misusing steroids. And in orthopedics, we have shifted from misusing steroids to all these chronic ligamentous injuries, facial injuries, tendon injuries. Now we are injecting these PRP and stem cells, and sports physicians are doing it. Plastic surgeons are using it for skin regeneration. You know that there is one Ravi Kumar Chitoria in Jipmer. So he is storing the skin graft in platelet-rich plasma. So when he takes an excess, suppose there is a very bad wound where he is expecting the skin graft will not entirely survive, 100% may not survive, only 50-60% survive, then he takes some excess graft and stores it in the fridge. Because when there is a loss, there is no need to go and again do the surgery. He takes the extra from the fridge and uses it for a second time grafting. that he stores in platelet-rich plasma, and he has shown that it has improved the survival of the graft and it has improved the take also. So this is the message which I conveyed today to the ophthalmologists also in the Ophthalm Association. So the main purpose of my talk is to talk with all specialists. So this regenerative medicine is applicable to all specialty, and only when we talk, when we have a cross talk, we can improve. Actually, this limbal stem cell therapy happened only because Dr. Sangwan talked to a plastic surgeon. He talked to a plastic surgeon who was doing something called meek grafting. When they do a skin graft, they they divide it into multiple small stamp-like bits, which they call meek graft. And only after seeing the meek graft done, that was a suggestion taken from a plastic surgeon, which Dr. Sangwan applied for his corneal blindness. And today, India is the top country treating, reversing corneal blindness with limbal stem cell therapy more than 20 years. And all the surgeons are getting treated in all the tertiary eye care institute, whether it is Shankar Nethralaya, Aravind Eye Hospital, it is Narayana Nethralaya, it is LV Prasad, RP Center, all these tertiary eye care centers. This procedure is not only done, it is trained. All these surgeons, corneal surgeons, are getting trained in this, and every tier 2, tier 3 cities in India have capable cornea surgeons who can reverse corneal blindness. And this is not the case in every country in the world. So India is on top of it. So this is what I want to emphasize, that we can take from each other, from the knowledge of the plastic surgeon, from the knowledge of the ophthalmologist, from the knowledge of the orthopedician, from the knowledge of the vascular surgeon, gynecologist. Today, gynecologists, endometrial thinning, Asherman syndrome, the IVF failure, the ovarian regeneration, they are using platelet-rich plasma and stem cells. They have taken it up in a very big way. So all their conferences, OG conferences, there is a session where they are talking about platelet-rich plasma and stem cells. So they have taken it up in a large way. Anesthetists have taken it up in a large way as pain physicians. So a group of anesthetists who wanted to specialize in pain physician, now they are taking up regenerative medicine. So wherever they are doing ablations, so you need not ablate the nerve unless it is a terminal situation. So in a terminal cancer, in a terminal situations, you can do ablations of nerve. But if you can regenerate, it is possible to regenerate. Now, the pain physicians are injecting platelet-rich plasma or bone marrow concentrate stem cells, and they are also helping in so many patients to regenerate the musculoskeletal tissues. Dental surgeons are doing it, and then my friend Dr. Shankar Narayanan, he has done a lot of cases of submucous fibrosis, osteoradionecrosis. So many indications are treatable with stem cells, and many of them are already being done autologous, and the future is allogenic. Next slide. So just before I end, these are some of the cases which we have done. Here you can see this is a boy. He is an MBBS student who came to us from Lakshmi Narayana Medical College when we went there to give a lecture. When we said we can regenerate cartilage, muscle, bone, he said, "Why don't you regenerate my hair, sir?" So this we did some 7-8 years back. So you can see hair regeneration. We used his own platelet-rich plasma, 4 doses. And skin regeneration, you can see diabetic ulcer. Endometrial regeneration we have done. So we have not only increased the thickness of the endometrium in Asherman syndrome, we have also increased the angiogenesis. Here you can see the red Doppler. It is showing that the angiogenesis, you can prove not only with the angiogram, you can also prove with a Doppler. So this we have proved in a case of endometrium, thin endometrium. Next slide. So this is testicular regeneration. You can see the number of sperms less from oligospermia. It is not only increase in the number of sperms, but their motility also. Everywhere it is not anatomical healing, it is also physiological healing. When we apply regenerative medicine, it is not only anatomical healing, it is physiological healing. And this they have proved in ophthalmology in retina. Dr. Naresh Babu from Aravind Eye Hospital, he did it for macular hole. So he combined platelet-rich plasma with internal limiting membrane peeling, where initially they were getting only anatomical healing of the retina, but now they are getting back vision also. So this is mucosal regeneration for oral submucous fibrosis. And the third slide below is the histopathology. So I think again, Dr. Rajendran, my classmate, and probably Dr. Murali can explain this better. So on the left, you can see that is the chronic, that is the severely fibrosed submucous region where the collagen is disorganized collagen, ground glass appearance with multiple chronic inflammatory cells. Whereas on the right side, you can see 6 months later, you can see the wavy pattern. Collagen typically is a wavy pattern, normal is wavy pattern. You can see the inflammatory cells are gone, and you can see some new blood vessels. This is proof of angiogenesis in histopathology. So we have proved angiogenesis after stem cell therapy with histopathology. We have proved with Doppler, we have proved with angiogram. So there is absolutely no doubt that stem cell therapy, how it does regeneration, it does regeneration by angiogenesis. And again, you remember angiogenesis is always coupled with neurogenesis. Next slide. So this is the angiogenesis. Already I showed this picture. So then cerebral palsy, neural regeneration also, we have done a few cases. Next slide. So as I said, this for Parkinsonism, it is already approved. So this is one last slide which I want to emphasize. This is post-irradiation skin fibrosis. Actually, post-irradiation complications, there is no cure, and stem cells and hyperbaric are the only cure which is available. Please read about it. Please go through the literature. See the case series. If possible, we will do some clinical trial, and then because there are a lot of evidence from skin to bone. So when there is a oral cancer, you can see this patient, you can see the mandible they have already done for cancer. They have done a mandible surgery, and there is a skin is fibrosed. We went to give for submucous fibrosis, but he could not extend the neck. So we did for the submucous fibrosis as well as for the skin. And here you can see the post-irradiation skin, how it has turned from a fibrous scarred skin to a near normal skin. So then there is a gluteus medius. This is PRP injection. So just I am showing some of our cases where I have shown every tissue in the body can be regenerated, including the avascular cornea, avascular cartilage. Next slide. Why not the other slides, other tissues? So this is as you see the vitiligo, where this is a young boy. So we took the stem cells and melanocytes from his hair follicle. We took 30 hair follicles from the occipital region, from the back of his head, and from the 30 hair follicles, we extracted his stem cells and the melanocytes, cultured them, and we injected it along the periphery of the lesion, and you can see that it has produced good pigmentation of the skin, which is almost normal. Next. After 5 sessions. Next slide. So regenerative medicine is actually the using of products derived from body's own cells, as well as the growth factors like the platelet growth factors. And then with the combination, we can reverse the debilitating effects of multiple pathologies, including musculoskeletal pathologies, which I deal as an orthopedic surgeon. I deal with musculoskeletal pathologies, but it is also for other indications. And you should always remember that it is done either alone or in combination with surgical procedures. We can always do a repair of the ligament and then inject the stem cells. We can do a repair of the bone and then inject stem cells. We can do a repair of the retina and inject the PRP. So it can be combined with surgical procedures, and that will give a very good result. Most of the flaps, when the plastic surgeon feels that they do a flap in a very, very critically poor limb, where the chances of failure are there, when they combine the surgical procedure with either platelet, with a regenerative procedure like a stem cell therapy or a PRP, then the success rate is better and the tissue healing is much better. Next slide. So these are the products from our research. We have made the plasma into powder form. So this platelet-rich plasma, we have lyophilized and made it into powder form. We have also made the fresh frozen plasma into powder form. So for our soldiers, when the soldiers are injured in the fight, when they suddenly lose blood, if we can take their blood, we train the soldiers, we give 6 months training when they select the soldiers. So when they are getting trained, if we take their blood and convert it into powder and put it in their own kit bag, they are carrying their kit bags to the battlefield. So they will be carrying their own blood in the form of powder in a pouch or in a container, which can be reconstituted with a saline pouch, which goes along with it. And then this is already available in French army. It is available in German army. It is available in Israeli army. It is to be available in US army, and we have all offered this to Indian army. So these are some of our products which we have made from the blood and from the stem cells. Next slide. Thank you for the time. I really thank Dr. Venkatesh for taking pains to do all these things, and we are really grateful to you, Dr. Venkatesh.
Thank you, sir. There are a
Thanks
few
for the-
questions. Yes, ma'am, please.
No, I thank Dr. Ravi for an extensive talk on this new area and a lot of potential as we can see. And I think we can have more discussions on how to go about individual patients in each specialty and have a few trials with Dr. Ravi and see how it's getting benefited to our patients. Thank you, Dr. Ravi.
Thank you, madam. Thank you so much. We can take up some of the questions.
Yeah, yes, sir. There are a few questions in the chat box and comments as well. So you can probably.
Yeah.
So I will read it for you, sir. A couple of questions.
Yes.
Which is better outcome, sir? Allogenic or autologous stem cell therapy? Any success in using xenogenic stem cell therapy?
So autologous is more successful up to the age of 75 to 80. So only when the patient is very old, 80 years, then his own stem cells may not be very healthy, so very powerful. So in those cases, we have allogenic stem cells. So most of the time, it is autologous, which is very good. But allogenic is also good and it is available. Autologous cannot be made available in every place, so you need a team, whereas allogenic can be available in a bottle, so anybody can buy it. So that's the advantage of allogenic. So that's also xenogenic is there is no need to go for xenogenic. We have enough stem cells, human stem cells, there is no need for xenogenic.
So there is another question on a lighter note.
Yeah.
Why does India have more approvals?
What?
Why does India have more approvals for stem cell therapies? Are
Yeah,
there
that is
randomized control trials before approval for hair regrowth?
so all these approvals have come only after randomized control trials. These are all the government DCGI approved. It is the same process like any drug. You are prescribing paracetamol, how it got approved. You are prescribing gentamicin, how it got approved. It is the same approval process which is applied to these stem cells also. So it is the same system through which this has come. And you can have as much belief in stem cells as much you believe in a paracetamol or a garamicin. So that's the answer for the first question. And what is the second question?
The second question
For
is
hair growth.
hair growth. RCT for hair growth.
No, yeah, that for the condition medium, it is available. It has been submitted to the DCGI and the approval has come only from the DCGI based on the clinical trial. And a lot of dermatologists are already, though before these things got approved, autologous platelet-rich plasma, not stem cells, even platelet-rich plasma, which is much less powerful than the stem cells, they have the potential to do hair regeneration. And so most of the dermatologists stop with the platelet-rich plasma when that itself is able to give them good results. They don't go to the next step of stem cell.
If there are any further questions from the audience, you can unmute yourself and you can ask directly.
So surprised to know wound healed without skin graft. Yes, that is the strength of the stem cells. Yeah. And somebody did not like my characterizing Rajinikanth, but that is only for the sake of comparison for the cells. Don't take it personally.
It was a fabulous talk, Ravi, as expected. Coincidentally, today the NEJM had published a paper on type 1 diabetes, beta cells, where
Oh,
there is a product
oh,
already
okay.
available. It's a commercially available product
Okay.
which has been used in 14 patients,
Okay.
and it has shown insulin independence and the blood sugar within the range. So you would be interested. I shared that paper this morning. I think you must have been busy.
Sure, sure, sure.
So definitely it will
Yes,
be a
yes, yes.
stimulus for
Definitely will go through.
India also. It's a commercially
Yes.
available this is an allogenic embryonic stem cell derived commercial product, which has been
Okay, okay.
injected intraportally into 14 subjects, and they have achieved some remission. But I agree, these all
Okay, okay.
have to undergo rigorous trials in our country because this is a very costly product.
Yes, yes, sir. So you know the cost of ciprofloxacin when it came.
No, I'm not telling about, we should do indigenously because this product is
Yeah, yeah.
from US, and probably
Yes.
for to come to India may take time.
Indian product will come, sir, because already we have what we have approved. The for GVHD, the US has only approved now this bone marrow, allogenic bone marrow cultured stem cells. So we will never be dependent on any other country because we have enough source of stem cells, so we can make that here possible.
Ravi, lovely presentation. And any experience of using stem cells for cancer therapy?
So that's a separate topic, sir. I think we will have it a separate topic on that because stem cells have been used um, to carry the drugs. So the cancer drugs have been tagged to the stem cells and have been delivered so that they kill only the cancer cells. So the unnecessary side effects of the cancer drugs to the normal cells is avoided by tagging the cancer drugs to the stem cells. That is one application. And then in neuroblastoma, and there are certain cancers where they have used a hematopoietic stem cell therapy after this the immune suppression. So there is a role for stem cell therapy in cancer. And there is one more big topic uh, which I think the oncologists and we should definitely ask the oncologist to talk about this cancer stem cell because that's a separate big topic where you can see the cancer metastases because the drugs, the chemotherapy as well as the radiotherapy are not able to kill the 100% of the cells. There is a small population of cancer stem cells which sustain the very hypoxic stages. So they thrive in severe hypoxia and they are able to resist the radiotherapy and the chemotherapy, and they are called cancer stem cells. And they are once the chemotherapy stops, then they spread to the other organs. And so this cancer stem cell is a separate category, and that needs an elaborate lecture. And I think we will get it from both sir. We have a lot of legends in our group, so I think we should organize one talk on that subject.
Sir, what about disc
Thank you.
degeneration, sir? Lower lumbar disc degeneration, which is a very common clinical problem.
Yes.
Do we have
So
therapies for that?
actually, there are the trial is now ongoing in India. So already the clinical trial is ongoing in India, but already there is a product available in USA. So they have taken the disc which is removed from during surgery. They remove the disc. So in one company in USA, they have taken this disc material and isolated the stem cells, and then they have grown the stem cells, and then discogenics. So that company they have come out with a product, and so soon it will be available. There will be an Indian version will be available, and a foreign version will also be available.
Dr. Ravi, thank you for your nice presentation. Very nice.
Thank you, sir. Thank you so much.
Just one comment. I think
Yes,
in
sir.
India, as Dr. Murli pointed out, I think we need to be rigorous in clinical trials.
Yeah.
So our endpoints are very clear, and because one of the concerns, is people should not be, in particularly in like private practice and all, should not be abusing, available stem cells for like in a variety of conditions where the benefit is not like clearly proven. I think that's the caveat. I think it's very important to emphasize.
Sir, actually, I hear this often everywhere, wherever I go, I hear this often. But the thing is that bad people are there in every specialty, in every business, in every profession.
Right.
So there will be misuse. There will be misuse, and we should be able to judge when we want to go for treatment. We should be able to do a proper ground search, and then see who is doing proper work, and then choose. Because always cheaters are there. It's never going to stop. It's never going to stop, and that should not be a reason for because I hear this often. So we have seen surgeons just cutting the abdominal wall and then claiming they have done appendix, and then they have claimed the money.
Yeah.
So we know Andhra. So there will be bad people. So that does not mean that surgery is bad. So this talking about, whenever I talk about stem cell, then somebody comes and says, so we should be very careful. This can be misused. Yes, it can be misused. It is true. It can be misused, but that misuse is never more than what it was misused for other things. So, and the other point which I want to emphasize is, thanks to you that you have raised this, unless we ethical people come into this field, if you don't come, if you are ethical, if you are hesitant, then the fly by night operator will happily jump into this. He will make money before you realize. And that is why I am giving talk everywhere to impress upon people, and then take it up in a honest way. You do the research, and then unless we get involved, it will always be the fly by night operators who will dominate the scene. So that should not happen. So thank you for raising that question, sir.
Sure, Dr. Ravi. Thank you.
Are there any further questions?
Sir, this is Dr. Sashi, ophthalmologist. Ravi sir,
Yes, Sashi.
just want to
Yes,
know
Sashi.
if we have these corneas being transplanted, but we don't have adequate corneas. Can stem cells help in regeneration of those donor corneas?
Yes, yes. So actually, this is what we are trying to do with the Rajan Eye Care. So today we had a meeting there. So we are trying to see if we can extend the storage from cortisol to optisol now by incorporating stem cells. Whether it is possible, already research has happened. Already some positive results have come. So we are trying to organize a study. This is going to happen only in the lab. So this lab part we are going to start. Definitely, it is possible that we can heal the cornea outside the body. As I said, already it is proved that the cornea is healing outside the body given the proper conditions. So with stem cells, it is much possible, and already articles are there, and we are going to do it. And I will involve you also, because you are one of my known friends. You is interested in stem cell therapy. Dr. Sashi, for others, is an ophthalmologist based at Salem, and he is a product of Aravind Eye Hospital. He is a vitreoretinal surgeon, and then he is taking up this in a big way.
Sir, one
So
more
as I said,
thing I
yeah.
just want as a concluding remark. We should
Yes,
have
madam.
some strict criteria for which patients will be included in these sort of a trials, because I think the clinical criteria is very, very important, and we should have strict guidelines in selecting patients for stem cell therapy. For example, if you take cerebral palsy, all the cases which have undergone a lot of damage, and they have gone to a point of no recovery, I think implementation stem cell therapy at that point of time how much benefit it is going to give to the child. So I think inclusion criteria as to when you include patients into the stem cell therapy, I think we have to have very strict guidelines.
Yes, madam, very much agreed. But what I would like to say is, what you are thinking as it is gone beyond repair. It is not so. Even in those cases, we have seen that there is a reduction in the spasticity, which several years after the thing has happened, even at 8 years, 10 years, 12 years, when the spasticity comes down, the child is at least able to sit with balance, able to stand with balance. The mother is able to be away from the child for at least half an hour, not carrying the child all the time. So what we are thinking now today is beyond, is not really beyond. So when you set the guidelines, I think you have to read more. You have to, you see, you witness some of the cases, and then you set the guidelines. So it has to be a collective work, and then you have to involve people who have done this work, talk to patients. So one more important thing is, we never talk, we involve the patients or the attenders when we decide the criteria, so clinical criteria. So what do the patients want? Do we know? Do we ask the patients? No. So unless, what is their observation? So this team which decides the clinical trial does not have a patient component in it. The doctor decides, the drug controller decides, the pharma company decides, but the patient doesn't, is not involved in the decision making. At some point of time, that some aspect, I think we should take the patient also, particularly patients who have undergone the treatment, and unless we do that, it is an injustice to them.
Thank you, sir. If there are no further questions, can we conclude and call it a day?
Yeah, thank you, Rakesh. Yeah, it is time for me also to travel.
Yes, sir. It was, this was a very big session, almost 1.5 hours of uninterrupted the lecture on the introduction to stem cell therapy and its current status in our country. So thank you so much, sir. Thank you for being part of this and sharing your expertise and opening your eyes regarding the possibility of cutting edge therapies that are available for our most unfortunate patients. One final question I wanted to ask you, sir, before we conclude. I have right now a transplant patient, about 10 years post-kidney transplant, who's got critical limb ischemia, no options. He's got multiple vascular occlusion, and his endovascular intervention also failed yesterday. So would he benefit from this kind of sort of therapy?
Definitely, these are the cases which were subjected by Dr. Rajkumar and his team in MMC. So you have in Chennai, if the patient is in Chennai, Dr. Rajkumar is the ideal person. Dr. Ilanjeraladhan, he was also involved in the trial when Dr. Rajkumar was there. So he was a assistant professor there in the Department of Vascular Surgery. So you can refer the patient to these vascular surgeons who also have a knowledge about these stem cell therapies.
Are there any downsides to these treatments, sir? Downsides to stem cell therapy?
Cost is one downside now, because this therapy is going to cost for this patient, if he is a 70 kilo person, this 150 million stem cells is going to cost him 1.6 lakhs. So if he's a 85 kilo person, he will need 200 million cells, which is going to cost him around 2 lakhs. So cost is one downside. And other than that, there are only minimal adverse reactions like fever, and there has been no major side effects.
Right. Thank you so much, sir. I think with that, we will conclude today's session. And I would sincerely thank all the members who stayed back. At one point of time, we had almost 45 members attending the meeting. That shows the considerable amount of interest people have shown. And by the end of the meeting as well, we still have 25, 26 people logged in. And that shows a lot of interest in the TMC Medalogs. I hope this trend continues. Thank you all. Thank you very much for joining us, and have a great day.
Thank you, sir. Thank you, Dr. Ravi. Thank you. Yeah.
Yeah, bye.
Bye.
Thank you.
Thank you.